Yes.
Great. So we're going to go through a COVID update, and it takes about 30 minutes, and then we can do some questions. So COVID's pretty tough, isn't it? This whole situation is really challenging, and I think we've got to really focus in on remaining hopeful. I think emergency medicine is probably about the most hopeful specialty. I think hope defines emergency medicine in many ways, in that we when we refer patients, we do it hopefully. We're hoping that the specialty can help the patient, and we do that time and time and time again, even though we're often going to get knocked back, because we do it because we hope the people that we're speaking to are going to be able to help these patients that come into us. And I think emergency medicine really defines hope. But I think what allows you to remain hopeful is this. COVID's really challenged our relationships, because we're more separated. But the more I work in anything, whether it's an emergency department or a business, the more I realize that productivity and happiness and really achieving things special is around maintaining the relationships that support you. And those relationships really are the foundation of your work-life balance. They're the foundation of your operational safety. And they're the foundation of your inspiration. So we really must put as much effort as possible into maintaining the relationships with the people that we have around us, despite these challenging times. So we're just going to talk a little bit about the transmission of the virus. So this sort of infographic just describes when transmission occurs. So 47% of transmission occurs in the pre-symptomatic phase, about 38% in the symptomatic, 6% in the asymptomatic, or people that never really get symptomatic, and then 10% is from the environment, so fomites infection or touching things. And what's really interesting is that the majority of the infection is in pre-symptomatic people, and those people will be spreading the virus mainly by bioaerosol, i.e. how they breathe the virus out, and then a little bit of droplet, because they're not actually coughing or sneezing, so their droplet spread is going to be minimal. But the majority of their spread is going to be through bioaerosol. And then the people that have symptomatic, their spread will be through droplet and through bioaerosol. So the majority of the transmission that comes from pre-symptomatic people, and in that group, it's mainly bioaerosol. If you look at when people are infectious, this is the exact opposite of SARS-CoV-1, which we saw nearly a decade ago. And that people with SARS-CoV-2, so the current coronavirus, are most infectious in the 2 days before they become symptomatic. And then their infectivity drops from pretty much the day of them developing symptoms down to a week. So after 1 week, you've produced so many neutralizing antibodies that actually you're not really shedding virus to be infectious, which is really the exact opposite of as I said, of SARS-CoV-1. And it's really understanding this has shifted the way I look at this virus a little bit, because with SARS-CoV-1, we were really very concerned about aerosolizing generating medical procedures, and as we should be with this illness. But in terms of infection prevention and control, it's the people that are early in the illness that are going to be shedding the most virus, and those walking through the door that don't actually know they have it. Just to that end, I thought it was important to just revisit our screening criteria. This is the screening criteria that we have, that we're going to essentially isolate and treat anyone as potential COVID if they have symptoms or if they have an epidemiologic contact. That's essentially it. And the Cochrane collaboration did a pretty good review of different types of screening. And although this infographic is a little hard to follow, if you look at the right-hand box where it says accuracy, the blue bar is the false negative rate. So what sensitivity then would be if you take the whole bar and take the blue away from it. So if you look at the first blue and red bar, if you look at just symptoms, the false negative rate is between 100% and 40%. So that means that if you just use symptom screening, you're going to miss between 100% of people and between 40% of people, depending on what system you work in. If you use temperature, your epidemiologic and travel contacts alone, then you're going to miss between 77 and 100% of people. if you use temperature and you use symptoms, you're going to miss between 31% and 88% of people. So what that tells us is that the screening criteria are really very limited, and that comes down to the fact that a lot of the people that are transmitting the virus are pre-symptomatic. So how that affects me is really the way that I operate. I don't look for a reason to use extended precautions. I look for a reason not to use extended precautions. I assume everyone is going to give me COVID before I walk in the room, and I have to have a really good reason why I'm not going to use extended precautions. And then if I decide that this person's been in the house, they've been in the house for a long time, they've clearly got another illness, their contacts are extremely low, their overall risk is low, and right now our incidence is very low, so that's reasonable. Then I will use the normal kind of sessional contacts protection that we're using. So rather than trying to commit an error of omission, I'm much more happy to commit an error of commission. And then after the sort of 3-phase screening, which is the front door, the nursing screening and our screening, and you've done some tests and you've got an extended history, I think it's really only at that point with multiple sources of data that you can make a decision about whether or not the person is at risk of having COVID. And if you're not sure, do a sentinel swab to keep everyone safe. It's going to talk a little bit about variants. So there's a lot of sort of worry about variants, the viral variants that are around. There's 3 main variants, and they kind of correspond to where there's large areas of spread. There's the UK variant, which is the B117, the South African variant, which is the B1351, and the Brazil variant, which is the P1 variant. And what we can see is the UK variant definitely has increased transmission. It binds with a higher level of affinity between the spike protein and the ACE2 receptor. There's a possible increase in mortality. When you look at the study, it's not really convincing. It was a very slight increase in relative risk, but a tiny increase in absolute risk. The South African variant, though, is interesting. It definitely has increased transmission, but it's clearly showing this thing called immune escape. And what immune escape is when you can catch the virus twice. So in South Africa, they've seen very clearly people that have had SARS-CoV-1, SARS-CoV-2, sort of the OG SARS-CoV-2, the wild type virus, and then they've gone on to get the variant. So it clearly has immune escape. The Brazilian variant P1 is also similar. The data that comes out of Brazil isn't as good for various socioeconomic reasons, but it shows probable increased transmission and probable immune escape. And when we look at the variants in Canada, the dark red dot is the UK, the sort of pink, the sort of lighter red dot South African, the pink dot's Brazil. We can see here in New Brunswick, we've got 4 UK variants. I think those 4 UK variants probably work in our emergency department. You can see UK variants really throughout Canada, the most in Ontario, 236 cases. And there's a couple of cases of the South African variant in BC, Quebec, and 1 in Nova Scotia. So really the variants are everywhere. So, and that's a real source of concern for public health departments, because these things spread more easily, and that's obviously worrying. We're going to talk about how they affect vaccines a little bit, but let's just start with the vaccine. There's 10 vaccines that are approved for use around the world. The 3 at the top are the ones we probably know the most about, which is the first one is the Pfizer-BioNTech RNA vaccine. That's the one that I've had. The second one down is Moderna. The third one down is the AstraZeneca vaccine, or the Oxford vaccine. And those vaccines, they all work in a kind of pretty similar way, actually. So the Pfizer and Moderna one are RNA vaccines. So they have a plasmid type coating that when you get it injected intramuscularly, the RNA is transcribed, produces the spike protein, and you produce an immune response to the spike protein. Those first 2 vaccines were trialed when there weren't any variants. So we don't really know how they respond to variants. The latter 2 vaccines, the J&J and the AstraZeneca vaccines, are both adenovirus vectors. So that's a kind of like a cold virus that's been tweaked that carries double-stranded DNA, and used in both in 18-year-olds and up. You can do them both with 1 dose, actually, or 2 doses. And because the adenovirus, the J&J vaccine, was trialed in South Africa when the variant was around, we know it is effective against the South African variant for preventing death and serious illness. There is increased transmission. For the AstraZeneca vaccine, obviously, which was the Oxford vaccine, we know that it's effective against the UK variant, less so, but definitely reduces death and significantly reduces death and serious illness in all the groups that's been studied. So not quite as you're more likely to get the illness, in short, if you have one of those latter two vaccines, if you get a variant, but you're still there were really no deaths in either of the intervention arms, whether or not it was variants or not. In the J&J or the AstraZeneca vaccines, which is really very reassuring. And I'm less worried as a clinician about whether or not I'm going to get mildly ill. I'm more worried about if I'm going to get ARDS or die. And it looks like those latter two vaccines definitely protect against that, even though they prevent the illness less. What we don't really know about any of those vaccines is how it affects transmission. From your knowledge of immunology, you'll know that it's actually IgA antibodies that provide your immediate host response against mucous membrane invasion. And actually the vaccines don't really affect the expression of IgA very much. They do have a massive effect on IgM and IgG initially. So it's likely that they reduce transmission. We just don't know that yet for sure. In terms of how we're doing in Canada, we're continuing to vaccinate people. We've managed to vaccinate about 3.3 cases per 100 people, and we've given just 1.25 million doses of vaccine. If we look at that sort of comparison worldwide, we're the brown group, and the brown line is one of the ones on the bottom. So we're not really vaccinating. When we look at the rest of the world, we're kind of in the bottom of the pack, and that's partly because, or mainly because, we don't really produce our own vaccines in this country. That will be changing, but that won't be changing to the end of next year. So yeah, vaccine rollout's been a little slow in Canada. I'm just going to switch over to PPE. I can see Crystal's in the audience, so I'm going to try and do my best not to confuse people and misrepresent best practice. But these are the really great posters that the Horizon and IPC produced that essentially describe the donning process for a normal situation. So hand hygiene, gown, putting on a mask, putting on a respirator, and then eye protection and gloves. And that's something that we all do very regularly for people that we're going to use droplet contact precautions on. One thing I just wanted to clarify a little bit was the role of eye protection. If we accept that one of the most significant routes of transmission is bioaerosol, i.e. you breathing out an invisible cloud of virus that floats around the room, we know that actually you can catch COVID through your eyeballs from bioaerosol. We know that you can immunize people with flu viruses if you aerosolize them, and the flu virus can get into their eyes. They'll actually get seroconversion. Therefore, if you want to stop yourself from getting COVID by walking around the department or by going into a room to do an AGMP, you need to have a goggle. Goggles, according to industry standard, need to be fit tested. The fit testing isn't like really as onerous as it is for a mask, but it's basically check that it fits. It needs to be comfortable. It needs to give you adequate protection. It needs to be indirectly vented, and it needs to be something you can wear for the whole of your shift. That's different from the use of a face shield. Face shields are crap or already offer zero protection against bioaerosols, but they offer enhanced protection against basically splatter and droplets. So the way that, understanding the evidence, I will protect myself in my practice is I will wear a goggle for all of my shift. And I've managed to find some tightly adhering goggles that actually have a reader lens in them so that I don't have to wear glasses underneath. And then if I'm going to do an AGMP, I will add a face shield. I think using a face shield on its own really does not make sense based on the evidence that's out there. I want to know that my eyes are protected mainly from aerosols and not from droplets. When we think about our practice a bit more when we're donning, we need to make a few adjustments to the posters that the hospital currently has around. One of the challenges that we noted very early on was that actually we can't hear anything when we're in the room doing something complex because half the team are outside, half, 2/3 of the team are inside, and it's very difficult to communicate between those people inside the room and outside the room. And what we've found with multiple sort of tests or experiments is that actually the headsets, these bone conduction headsets LA to hear the air are actually very good. So this poster, which I had to adapt the layout for a slide because the this perspective is different, but this comes from a poster that basically incorporates the hospital donning system with the system for putting on using a headset. So you clean the headset, put the phone in your pocket, wash your hands, put on the N90. Sorry. So you clean the headset, put the phone in your pocket, and obviously match the phone to your headset, wash your hands, and then put on the gown. The level 3 gowns that we use are different from the level 2 gowns that we use. The level 3 gowns have 2 layers, that you cannot do up on your own. So there's a picture of one of the nurses there putting on the first layer and then putting on the second layer. And you can tell if someone's not on the layering properly because their back is open. You then put on the N95, you put on the headphones, you put on the goggles, put on the face shield, then you put on your gloves. And there's another poster that I've done that's the reverse of that, basically for doffing. Sorry for taking your protective equipment off. Just going to talk a little bit about the RSI checklist that Jay main designed. I had a little bit of input, and other people had a little bit of input into this, and just bring your attention to a few things. The first thing is that we have a hot team and a cold team. So you have 3 people in the room and 2 people outside of the room if you're going to do some kind of AGMP on someone that you think is at risk. And that's really everyone that we have to intubate right now. So in the room, you have 1 MD, 1 RT, and 1 RN. And outside, you have 1 backup MD and 1 RN. That's your team. And the second thing I want to bring your attention to is that we have these kind of small airway boxes. There's another slide to follow that has the airway equipment in it. But if you think this person's a difficult airway, they don't contain LMAs or crike equipment. So you just want to have eyes on that in the airway cart, and maybe bring it to the table outside of the room. And then the last most important thing is that in these circuits, you need to, the first thing that connects to the tube is a HEPA filter, which will prevent virus from leaking out of the end edge keel tube into the environment. So this is currently our equipment system. So we have these little boxes, and that but they don't contain LMAs. They do contain all the basic airway adjuncts and everything else you need. They were tweaked recently based on a few critical events. But if you need LMAs or a crack kit, it's actually not in that. You have to get it from the airway cart and have a runner bring it in. One of the things we've done to make things a little bit easier is we've developed these lean drug packs. So before it took 66 steps to draw up RSI drugs, we now have a much leaner system that we designed with the nursing team and with pharmacy that's now down to 22 steps. That has instructions on the outside. They're kept in the McKesson. They're clearly labeled using the kind of international color coding system for anesthetic drugs. And that really reduces the time on task, makes things a lot easier. And they're really only for people that are 12 years and older, which is 40 kilos and older. We haven't made the pediatric ones yet. I'm just going to talk briefly about the phases of COVID. So there's 3 phases of COVID that's generally accepted. The first is the viremic phase, where you have the kind of viral illness type symptoms, so headache, fevers, chills, aches and pains. The second, if you go on to it, will be the pulmonary phase, where you start to have a sort of viral pneumonitis, and you're going to develop some chest X-ray changes and some respiratory symptoms. And in the third phase, if you're unlucky enough, you have this kind of overwhelming inflammatory response that leads to multi-organ failure, renal failure, and the sort of whole host of multi-organ problems that you see in intensive care. Phase 1 particularly finishes after 7 days. You see the pulmonary phase between the first and second week, and the hyperinflammation stage sort of after the second week. This relates directly to how we manage people from a respiratory perspective, and this kind of way of thinking isn't perfect, but it is a way. It is one way of thinking about it, and I think probably not thinking about it this way probably accounts for some of the excess mortality in COVID patients at the start of the pandemic. So during the pulmonary phase, sort of in the second week, if you like, you are going to be hypoxic. You might be quite profoundly hypoxic. The key to those patients is that their hypoxia is due to a pulmonary problem that is both dead space, i.e. ventilated, non-perfused lung, and shunt. So in these patients, you have a serotonin mediated, platelet sort of activated problem with the microvasculature in the lung, which means you get decreased perfusion of alveoli, so that even if your alveoli are working, you're not getting blood to them. And you do have some inflammatory changes in the alveoli themselves, but in that initial pulmonary phase, you are less recruitable. So if you put someone on a ventilator with high amounts of PEEP, you're actually just going to contribute to the inflammatory response. You're going to cause problems with CO2 diffusion, and actually that may be one of the reasons why we saw excess mortality in the early phase of the pandemic. In these people, in that kind of initial pulmonary phase, the mainstay of respiratory treatment is awake proning, with the use of high flow nasal cannula and BiPAP, and adding in BiPAP if people are starting to get hypercapnic from tiring or their CO2 is going up. It's really not until the stage 3 where you have a much more ARDS-like illness. It's still not totally like ARDS, but where you are more recruitable, though a significant proportion of people won't be recruitable, where you can think about using high levels of PEEP. So it's in those patients that we're going to opt in to do invasive ventilation with intermittent positive pressure ventilation, proning, and ECMO if it fails. We do have this great thing on our website that talks about awake proning, and if you want to look at how you awake prone, it's basically turning someone regularly. I'm just going to show a clip from a brief video on how to prone someone who is intubated and ventilated. The take home is it's a lot of work. It requires coordination and checklists for it to work properly.
So I'm happy that we can go ahead. So, reintubation equipment, is that available? Yeah. Okay. So his eyes, we're going to pad and lubricate. If I could just have some...
It's going to move you forward to the bit where they actually flip him, just because it takes a real team kind of effort, and it has to be coordinated and trained. It's not just something I think you can do off the bat, not having done it before.
James, can you turn your volume up a little, please?
Yeah, crests and the knees. That's great. And if I could ask you just to put the sheet up. Okay. So Simon, in a moment, what I'm going to need you to do is I'm going to need you to pause the ventilator. Okay, so everyone's happy if they could roll. Exactly, perfect. And Simon, if you could pause the ventilator for me. Okay, I'm happy that's stopped. I'm going to clamp the tube. I'm going to disconnect here and place that into an angle control. Okay, all right. So the first movement will be to slide to the left of the bed on slide. So the patient will face the ventilator. Okay, everyone ready? On slide, ready, brace, slide. Okay, the next command will be to roll over to 90 degrees on roll. Everyone ready? Ready, brace, roll. Okay, and then if I could get the people on my left to put their hands on the top, people on my right to put their hands on the bottom, that's great. And then we're going to complete the prone on roll, ready, brace, roll. Good, well done.
So it's not completely straightforward, and there are really good checklists by the Intensive Care Society for what you did before, during, and after you prone someone. And if you're planning to prone someone who's intubated and ventilated, then I'd strongly recommend that you use something like this approach. Another problem with COVID that's people become increasingly aware around it are the neurologic manifestations. So the encephalopathy, you get it. If a COVID patient comes in and they're critically ill and their level of consciousness is dropping, they're unlikely to wake up regardless of what you do to their saturations, because there's a very high level of confusion and delirium and with COVID that can really impair someone's conscious level. We're going to finish with a few slides on therapy, and we're just going to start that off with just understanding the pathology a little bit of COVID. So we know that after the SARS-CoV-2 virus docks with the ACE2 receptor, goes into the cell, it causes a massive inflammatory cascade using interleukins, and which leads to endothelial dysfunction and edema in the infected tissue. There's platelet aggregation, which can lead to sort of localized thromboembolic events and and thrombus in situ, and on a kind of larger vessel perspective can cause acute coronary syndrome, coagulopathy, and coronary artery aneurysms, as we see particularly in children, so a Kawasaki's-like illness, and also strokes. That sort of leads to the therapeutic options. So a lot of the therapies are around preventing the problems with coagulation and hyperinflammation. The recovery trial is one of the most impressive trials I think has ever been done. It's essentially an adaptive trial, so it changes every time there's a new therapy that's proven to be better or worse. It's the same system they use in pediatric leukemia. It's around 176 UK hospitals, and it's considered 9 therapies. The first therapy that it showed to be effective was dexamethasone, produced a decrease in mortality. The second therapy that's found to be effective, most probably, though I haven't reviewed the whole paper, is tocilizumab, which is basically a biologic. It's an interleukin-6 monoclonal receptor antibody, and is shown to reduce mortality in people that are essentially critically ill. Things we know that doesn't work: hydroxychloroquine doesn't work. Colectra, which is a HIV antiretroviral agent, again has been studied in the recovery trial and a randomized control trial. It doesn't work. Donor plasma, so basically using convalescent plasma for people that have had COVID, in patients with COVID, doesn't work. Remdesivir, which was the first sort of major drug that we know became people started really talking about, apart from hydroxychloroquine, now in 4 randomized control trials, does not work and causes renal problems and is very expensive. Colchicine, the recovery trial hasn't published their results yet of colchicine, but there are other randomized control trials that show, despite the hype, if you actually look at the studies are negative. That also does not work. So that brings the end of my presentation. Thanks very much for listening. The more we develop our understanding of COVID, the more I think we're better armed to deal with it. I think we will get to an end of all this, and I think there is hope. And this was a picture of me at the weekend, ice skating and playing hockey on a river with my extended 10. So it is still possible to have some uplifting and exhilarating experiences.